You're watching CTOM TV. Knowledge is power.
How do clinical trials work?
So you typically have four phases of clinical trials. You have phase 1, phase 2, phase 3, and phase 4. The first phase is typically a dose-finding phase and a safety. And so they want to determine, what level can you give the drug at before it creates toxicity and side effects. The second level is to see if there is any, functional relevance to the drug. Is it doing anything? Doesn't mean you can't obtain that sort of information from the phase 1. I mean, sometimes you'll have a class of patients that have literally a few months to live, and they've been given this drug, and all of a sudden, 6 months later, 12 months later, at the end of the trial, they're still alive, or high percentage are alive. Then right away you have some significant data to move to the next phase, even though that was not the intent of that trial.
Right. So you've kind of collected your phase 1 and 2
and phase
data.
2 in a sense, yeah.
Okay.
It's not, you haven't actually collected your data, but you have a pretty good indication that this drug is going places.
Okay.
So then phase 3 is really, where the important information is. And so that's typically what we like to look at, is the phase 3 and the phase 4.
Well, what's phase 3 got?
So phase 3 is basically taking a group of patients and comparing. I mean, in general, what you do in most cases is you take the standard therapy for that cancer, and then you also take the standard therapy plus the tested drugs, and they compare the two populations.
Okay. So you have two groups. The control group is the one that's getting what they would have got anyway.
Yes.
And then the other
therapy
gets
right.
standard plus the other.
Plus the tested drug, yes.
And in your opinion, what are the pros and cons? I mean, I understand these are humans. You can't refuse to give them a treatment that can be helpful, and that's why standard care is included. But what are some of the problems with that approach, or confounding variables, perhaps, if any?
Well, I think you hit the nail on the head there. You can't really be testing on humans.
Yeah.
You can't be using humans as test subjects.
But I guess what I was asking more was, is it possible that the results from a clinical trial of a new cancer treatment, say a targeted therapy, are negatively impacted by the patients being on standard care simultaneously?
Very, very rarely.
Okay.
Yeah, there have been some cases that were fairly complex.
Okay.
I think more. The problem has been a lack of patient stratification in collecting patients for clinical trials.
Right, because until recently we haven't had the genetic testing to make sure people are in. Yes, that's right. Say a bit more about that.
Well, I first learned about this during IRESA and Tarceva trials long time ago. These are some early EGFR targeted drugs, and what they did was they looked at a population of patients with these mutations. They looked at a population of patients that were supposed to have these mutations, but they didn't actually test all the patients for these mutations. And so therefore the drugs failed the trial. But afterwards, when they looked at the subgroup and they realized, well, you have to have this mutation in order for the drug to work because it's designed against that, then they realized what a failure, why the trial was a failure, and how from then on, genetic testing for the molecular features that your drug is targeting is really important.
Yeah. I mean, it sounds so obvious now, but this is how long ago now?
I believe that was early 2000.
Yeah, so genetic testing was a very new thing.
We didn't get the human genome until 2005, 2006. So, we had a few genes that we knew of, and EGFR was one of them.
So we've learned a lot in the last 20 years, let's say, for sure. So what's phase 4 for a clinical trial?
That depends on many factors, but it's really fine-tuning the subgroup. So what happens after the phase 2 and phase 3 is you get a subgroup analysis. In other words, well, yes, the patients in general did well, but there's this group of patients in this trial that did incredibly well, and there's a group of patients that did really poorly. So the phase 4 wants to stratify and find out exactly who those patients were, why they did so well, and why the other patients did so poorly. So in other words, really defining the molecular features of that. That's more of a generalist approach to phase 4. I mean, phase 4 is really just, traditionally it's really just fine-tuning the efficacy of the drug and getting the doses and seeing how well it works.
Okay. But I appreciate that refining phase is necessary.
In the world of targeted therapies and precision oncology, typically that's how the phase 4 trials end up being, is a more of a patient stratification.
So this drug will work really well for these people with this genetic mutation.
But
don't bother with
don't
these.
have this other mutation, or that do have this other mutation.
Right. Yes, because...
And that's based on subgroup analysis.
Okay. Because there are often more than one mutation involved in someone's cancer.
And that's the biggest problem. This is where most clinical trials are failing, is they look at one molecular feature and ignore the rest of them. And, as we know, we have mutations that can improve the efficacy of a drug, co-mutations, and we can have negative co-mutations that reduce the efficacy of a drug. And prevent it from working.
So you have
or emerging mutations that only happen in a subpopulation of cells that also prevent the drug from working.
And would those turn up in genetic testing panels?
Yes.
Yes. So all that stuff you'd find out,
testing, yes.
Right? So, as you were saying earlier, for Canadian patients, there's a new initiative from the National Institute of Health to allow Canadians to take part in clinical trials. And I think they get to do so from here with their doctor administering. They don't.
I'm not sure how new it is, and we've seen everything.
I see.
So we've been able to work as an extension of a clinical trial, where the patient pays partial costs of the drug. We've had cases where the drug was shipped up to the local doctors or the doctors up north because the patient couldn't participate, and so they participated via distance. There's so many different options, The important thing is to find out what you need, what's going to be best for you, and then try to pursue it.
Yes, and it's important that, so for example, back to this clinical trial concept, if it's a clinical trial testing, say, an EGFR drug, just that one mutation, as you were just saying, it's very important that you don't then just get tested for that one mutation to see if you have that for that trial. You've got to have a broad panel genetic test so that you can see what other mutations might be involved and how that might confound your results or enhance them, or if in fact that's not the driving genetic mutation for you, and there might be something else that there's already a great targeted therapy for, because there are so many.
Yes.
Thank you for watching CTOME TV. Subscribe below and stay informed. You're watching CTOME TV. Knowledge is power.
Standard care versus precision oncology in general. So very general discussion, but at the same time, I've prepared myself with some statistics for you. We're going to focus for this next half hour specifically on North America, but we will absolutely answer your questions if you're from somewhere else and want to know. We've definitely, again, had clients from all around the world, so we can talk about pretty much every healthcare system. And what works and what doesn't, and how to get it. But just to start out, if we're talking about North America, essentially we're talking about two systems here, and they are quite different, but there is some interplay and overlapping. So we're talking about the Canadian healthcare system, which is a publicly funded system for the most part, and the United States system, which there's a little more funding now through Obamacare, but for the most part it's not. It's a user pay, and far more of what gets covered or doesn't is in the hands of the insurance agencies, whereas in Canada it's more in the hands of a board of doctors, oncologists, pathologists, and even economists to determine which treatments get the 2 thumbs up and which don't. So we're going to talk about all that in the next half hour. And mostly why we're talking about this is because we want you to know what's possible versus what is typically offered to patients initially. And why? Because it's certainly not your doctor out to get you. Certainly not that they don't care about the care that you're receiving or want you to have success in your treatment, but there are limitations in the things that they're able to provide for you. And understanding what's possible versus what's offered will really help you, help them, help you.
Well said.
Thank you. Okay, so let's see here. What if you had kind of your wish list that everybody out there who's just received a diagnosis of cancer, you know, understandably, like you're frantic, you know, maybe trying to hope for the best, or maybe just feeling hopeless, or all of the above, what are the things that you wish those people knew, like, right away?
Wish they knew, or wish they would do?
Well, let's start with what you want. What do you wish those people would do right away?
Proper imaging.
Proper imaging.
Yes, definitely proper imaging.
Okay.
And proper diagnostics is really everything.
Okay.
So, you know, I think an inherited genetic panel, a tumor DNA sequencing panel, perhaps a liquid biopsy sequencing panel, in a perfect world, get all three of them. Monitoring with exosome-based liquid biopsies, I think, is the way to go. It has a very specific niche in the monitoring aspect of it, but I think it's very complementary with PET-CT. I would like to see more PET MRIs. I don't know what's happening with that technology now. I know Germany and India have been using it, and when we've compared PET-CTs to PET MRIs in patients that have gotten them, they really seem to be on par with each other, you know, almost, you know, perfect mimics of each other. So we've seen...
Say that again?
So, well, we've seen cases where patients have had a government PET-CT, and then they've gone off to India or Germany or one of these places to get a PET MRI. And then they've come back with a PET MRI, and the PET MRIs typically show the exact same results as the PET-CTs.
So why get one then?
Because you don't have the radiation dosage of a CT.
Oh, I see. So it's the MRI versus CT on the end of the PET there.
Yes, that makes a difference.
Thank you.
Yes.
See, so you got to explain this stuff to us. So a PET CT has radiation, a PET MRI doesn't.
Has minimal radiation.
Minimal radiation, and you're saying that the results are equivalent.
Yes.
So
from what I've seen,
right.
You know, small amount of patients, but
I see. So that's why you're saying it would be great to see it, because then people can have fewer amounts of radiation and equal results.
Yes.
Okay, so let's go back to what you started with, what you wish people would do when they're first diagnosed with cancer. And the first thing you said is proper imaging.
Yes.
So if we're going to talk about, let's talk Canada, then US here. So in Canada, what kind of imaging is used typically for diagnosis, and why wouldn't you call it proper?
Well, you're using a CT scan at best.
Okay.
MRI too.
Okay.
Both of those are great for detecting shapes and shadows.
Okay.
But they do not look at biological activity, even with diffusion. And that's a problem.
Okay.
You need to have biological activity.
So shapes and shadows just tell you something's there.
Yes.
What does the biological activity tell you?
It tells you that population of cells is actively metabolic.
Okay.
And if it's highly metabolic, then there's a good chance it has a high chance of metastasis or growth.
Ooh.
So it allows you to target individual tumors. And, you know, many cases, a tumor will get targeted with radiation therapy or something, and it won't be the most aggressive tumor in the body. Just they'll target it just based on size.
Because based on a CT scan or an MRI,
yes, exactly.
Which is just showing the, as you say, shapes and shadows.
Shapes and shadows, yes.
Okay. Whereas the PET CT shows
biological activity,
which means how aggressive it is
and how fast it's growing.
How fast it's growing.
Its percentage of necrosis.
How much the cells are dying, and therefore how well the treatment's working.
Exactly, yes.
Where again, you can't see with CT, it's just, in fact, we've had cases where people have had their treatment ceased because on the CT scan, it looked like the tumor was getting bigger, right?
Yes.
And then it turned out the treatment was working fabulously,
Yes.
and it only looked bigger because there was so much cell death.
Exactly.
Yeah, and
so that's typically with immune therapy.
immune therapy.
We've also had cases of the opposite, where patients have been on treatment for quite some time, and when we got them a PET CT, we found that they never had cancer in the first place.
Yes, we have had that.
A few cases, yeah. So
yes.
but in most cases, what happens is the patient is staged incorrectly, and when we get them a PET CT, we see that they're actually at a higher stage than they were originally diagnosed at.
So proper imaging first. Make sure, that you do have cancer, and a PET CT is the best way to do that.
Exactly.
Or if you can get one, apparently a PET MRI, which is equally as accurate but less radiation. So that way you can find out, yes, for sure you do have cancer, where it is, which tumors are most aggressive. And then again, that can inform things like surgery and radiation. And even if there's a biopsy sample to be taken for you for further testing, then the surgeon can make sure that they take the biggest or most aggressive tumor.
Exactly.
Yeah, so lots of good reason to get proper imaging. So if your cancer diagnosis has been based on a CT scan or an MRI, you might not even have cancer, and there's a lot of information that you don't have. So yes, definitely. You also said then genetic testing. So some genetic testing can be done without a tumor biopsy, and some can't. So tell us a little bit about it, again, in your fantasy plan for people that have just been diagnosed. They're getting they're getting a PET CT now, and then what else are they doing with this genetic testing?
So there's a few points I'd like to really focus on genetic testing. A lot of times when we go look at a patient for genetic testing, the doctors typically say, well, we want to use the latest tumor because that's going to show the latest changes. The problem is that what you want to do with genetic testing is you want to focus on an older sample. And the reason you want to focus on an older sample is you want to have a good idea of what has caused the cancer in the first place. In other words, the key molecular features that started out the cancer.
Got it.
Because they're going to be in the highest percentage of cells in the body. So there's going to be early mutations, and there's going to be late mutations, and of course there's going to be emerging mutations. We really like to focus on the early mutations because they are going to be capitulated in all of the metastatic deposits.
Okay, say that in English.
They're going to be there throughout the vast majority of the tumor cells.
Oh, okay, got it.
In the body.
So they're guaranteed to be present everywhere.
Not guaranteed,
but or not guaranteed. Nothing in medicine is guaranteed. I'm learning.
Nothing is 100% either.
Right. Okay, so most likely to be there versus these emerging mutations that you might find in some
not necessarily.
All right.
So you want to focus your tumor DNA sequencing on a sample that is going to be the best example and representative of all of the metastatic potential.
Okay.
And that is by picking the early mutations.
Okay.
And typically the earlier mutations are going to be better targeted.
Meaning?
There's going to be more targeted drugs for them, more data on them, more information on them.
Because they're more common?
Yeah, they've been around longer.
Okay. All right. Well, they happen
early in the evolution of the tumor, and so they have the most amount of research on them.
I see. Okay, because more people might have those mutations.
Right.
Got it. Okay.
And so a lot of the changes we see when we look at later biopsies, the theory is that you want to look at the latest biopsy. But, if you look at the latest biopsy, it's a small snapshot of what all of the tumors in the body are doing. And it's going to be very inaccurate because you're just not going to be seeing what's going on in the rest of the cancer.
Okay, so that right there is really important for people to understand. That if your doctor is saying, let's look at the
latest biopsy. Yeah.
It might make sense on a certain level, but not really, when you understand the whole concept.
And a lot of the changes you do see in the later biopsies are going to be treatment related.
Okay.
So damage caused by chemo drugs and so on.
Right. So those are important, but not as important as those early mutations.
So so the thing is then you have your general mutations, you have your original mutations. So of course, emerging mutations and later mutations are important, but the nature of these later mutations and these emerging mutations, typically they're going to be at a very small minor allele frequency. In other words, they're going to be at a very small percentage. So your chance of finding these dangerous emerging mutations that may have a targetable drug for them is going to be much harder with the biopsy, because you're just randomly poking into pieces of tumor and hoping that it has that. So, and the problem is when you look at these mutations, one of the big mutations that we see a lot of is copy number variation. So we'll see a reduction in tumor sequencing or tumor suppressors, and we'll see a increase in proto and oncogenes. So increased copy number of them, which means typically higher expression.
Right.
So
that's not good.
No, and also when a gene copies itself, it typically copies itself through a process of retrotransposition, and that can create a lot of damage. So you get a copied, you get a series of the gene copies, but they're not copied perfectly, so they're probably mutated and non-functional or super functional, or just in a bad way.
Yeah.
Yes. So the problem, copy number variation, we see this all the time. One example is HER2. When we see copy number increases in HER2, it changes between the cells. So some cells will have higher copies than others, and it changes between the tumors. So when you look at the tumor as a whole, this tumor may be HER2 hot, and then another tumor next to it may be HER2 cold. Or some of the cells in that may have super high copy numbers, and then other cells will have lower copy numbers. So, you have to look at the type of mutations that you're targeting and understand how these mutations function in the role of cancer progression. So for these sort of mutations, what you want to do, you want to be looking at liquid biopsies. And, things like Garden 360 is an excellent panel. There's a bunch of companies doing different panels now. Foundation One has their liquid panel. They're kind of limited. They're not able to look at a lot of the genome. They look at specific regions, and they typically only look at about 90 different genes, 90 to 95 different genes.
I think it's 70 actually.
Is it? Okay.
I think so.
Okay. Maybe those are some of the fusion proteins they include then. So it's
not very broad.
It's not very broad, but
No.
that's the technology you want to use. And you can do that by looking for key mutations. So one of the things that we understand with lung cancers, after they've been on lung cancer patients, after they've been on EGFR inhibitors, is they have a tendency to develop an EGFR T790M mutation. That's what we call an emerging mutation. And that will prevent the standard therapy, which is the EGFR inhibitors, the first generation EGFR inhibitors, from working.
Oh, wow.
There's also a second mechanism that can cause progression in these patients, and that is called a CMET copy number variation. So we'll see increased CMET. So the best way to test for those two is with a liquid biopsy, because it gives you a representation of the entire body and all of the tumors together. Right. Not just, this tumor versus that tumor.
So if you're going to do fixed tissue sampling, you want to get one of the earliest
ones.
And then if beyond that,
you're looking for emerging treatments, you look at liquid biopsies.
Okay. Right, which is a blood test. As far as you at home are concerned, you just have a couple of vials of blood drawn, and then all of the magic happens in the lab. And typically those tests take about 2 weeks to get results back and find out what's going on. So even people who are quite late stage can really benefit from those types of tests, because they give you targeted information and make sure your treatment's going to be more effective. Okay, if we're still in the doctor's office, we've just got our diagnosis, and you're wanting people to do this PET CT or PET MRI if possible. You're wanting them to do the tissue test and some inherited mutations testing. Did we talk about that?
Yeah.
Okay, that would be the liquid biopsy, and then kind of monitoring those emerging mutations that way. And that's it? Are they good then?
Well, that's the general approach.
Ticked?
That's the general approach, yeah.
Okay, so if you've done
and
that...
And of course surgery. I mean,
Yes.
You want surgery. You want to remove the tumor tissue as much as possible.
Yeah.
At every
Understandably,
option.
people want to avoid that if they can, but getting active cancer out of your body as quickly as possible is the wisest choice.
It is, definitely.
Yeah.
The extent of resection is really a driving prognostic factor.
Getting all the tumor out means you're going to live longer.
Yes. I think there was a study, and this is, a very general-based study that showed that in most cases where you have a solid tumor, the stem cells that actually cause that tumor are somewhere in a ball 5 centimeters from
Away?
the core of that tumor. So in other words, if you have a tumor that's this big, to actually get rid of the stem cells that cause that tumor, if it's a primary tumor, that is, you take a ball this big out, which is
bigger than 5 centimeters.
No, 5 centimeters from each center, so 10 centimeters diameter. So
wow.
It's literally impossible to do.
We use radiation.
Yes, exactly, but that doesn't get rid of it. So, and we see this with cancers, bone cancers that occur in limbs, for example. For example, if somebody has a bone tumor in an arm or a leg or something like that, typically what they do is they'll cut the leg or the arm right off. And in most of those cases, that gets rid of the cancer.
Because it was within that.
It was in that area, yeah. Right. So that's removing the stem cell niche with the tumor.
So it's I'm sure a very, very traumatic approach, but highly successful if they've got that stem cell.
Well, that's where we first started seeing, the evidence that shows that the stem cell niche is not within the tumor. It's nearby, but not within the actual tumor. So just removing the tumor is not enough.
Well, okay, so we've got the imaging, we've got the genetic testing, and we've got the potentially surgery, and then we're monitoring.
Yes.
So we're using that information to find out which treatments are going to work for people.
Of course, yes.
And then we're keeping tabs on that, which we'll come back to in a bit. Okay, so that's their dream plan or wish. If everybody out there could know that those things are so important, then a lot fewer people would die of cancer, probably.
I think so. I think we'd see much longer survival rates. People do get treated that way. I see people getting treated very well. And then I also see a lot of people getting treated really poorly.
We're missing out again some of that key
opportunities, and really you want to focus your efforts on the diagnosis. You really do. That's where you want to put the money.
We hear a lot these days, which, based on the information I've learned from you and, my own reading, is a little confusing, but a lot of times patients will call us and they'll say, well, my oncologist said I should start with standard chemotherapy and then move to a targeted therapy, as a next step, which really is some of the opposite of what you're saying there.
Well, I think oncologists are conservative by nature. They're treating a lot of patients. They don't have a lot of time to look into the details of each patient. And they want to do, they're legally obliged to do what they know is best. They have to go with the information they have and the information that's approved. And in those circumstances, they're doing the best with the tools they have.
Valid.
And, obviously, you hear horror stories, but, I think most cases the oncologists obviously try to do the best they can and really try to do what they can with what they've got.
Which brings us back to Canadian healthcare and U.S. healthcare and kind of what's possible versus what is typically offered. And something that I talk with people a lot about is that there really are two reasons. If you were to say to me or Alex or anyone out there, why doesn't everybody know this, or why isn't this the standard of care? If all the oncology journals are saying that this approach to treatment is so much more effective and extending people's lives and reducing their treatment-related side effects, why isn't this just happening now? Well, there are two very good reasons for that unfortunately have nothing to do with you but will affect you. And one of those is what I call the information bottleneck. There's just so much information coming out every month. Alex and his team are challenged to keep up with it, and that's their job. That's all they do. An oncologist who's also, you know, seeing between 60 to 100 patients a week and has about 2 hours a week for continuing education, they're not going to be able to get through more than a handful of papers, if that. Certainly not the hundreds that are coming out every month. So that's one of the reasons why. There's just so much information. No one person can keep up with it as it pertains to all different types of cancer, and so we need to appreciate that. And then there's also, frankly, just the bureaucratic element. In a public healthcare system, there's only so many dollars in the basket, and those dollars have to be spread out to every possible health concern, some prevention, but mostly response to treatment and then emergency care across the country. On top of that, every province individually has the right to determine which treatments they offer and which treatments they don't. And there's all sorts of reasons why they may or may not choose to offer an FDA-approved, highly effective treatment for the mutations that are driving your cancer when the province right next door will offer it. So there's just so much variation province to province. And again, there's the very real limitation of dollars and just how much money there is to spend. Typically, these new treatments are a little more expensive than standard chemotherapy, so that is a legitimate concern. And even as Alex was talking about his ideal imaging approach for people, let's say the PET-CT, not the PET-MRI, although I know that's what you prefer, even when it comes to PET-CT, those scanning machines are pretty expensive. And there are numerous provinces across Canada that have private PET-CT clinics, but there are other provinces that don't allow that and don't have PET-CT as an option for cancer diagnosis. And certainly, in Canada, PET-CT is not used as a first-line imaging diagnostic tool, or even a second or a third, actually. No. In the United States, however, for all you might want to say about the non-public healthcare element that they have, they're pretty innovative, and they move a little more rapidly into adopting technologies like genetic testing and PET-CT. It's very common for a person from the United States to give us a call or begin to work with us, and they will already have had a genetic testing panel, and they will already have had a PET-CT, because while they're not guaranteed to be offered to you as a U.S. citizen, many oncologists are well aware of their value, and many insurance companies cover those tests. So that's wonderful. It's one of the pluses of the United States system for sure. Another contrast there, in the United States, there are thousands of PET-CT machines across the United States. In Canada, we have 40. Yes.
It's more than we had a few years ago.
This is true.
It's a start.
True. But it's important. The point I'm trying to make there, aside from there's some good stuff about US and what they're doing in terms of being early adopters, or kind of being more able independently as oncologists and as hospitals to absorb the new science, because they're not beholden to some federal or provincial body once something is approved. But really, where you live makes a difference to the treatments that you're going to be offered, and not because the treatments that are out there aren't better than what you're being offered, but because, as Alex was saying earlier, it's just not an option that your oncologist is allowed to offer to you, or perhaps may not even know about because of that information bottleneck. So what's most important is that all cancer patients understand that while the oncologist is a specialist in cancer, that is not the same thing as they know everything. It's not the same thing as they know all of the options that are available to you. And it's really important that you get those proper tests done right up front, so that your first line of treatment is the one that's going to be most effective for you. Also, in the Canadian public healthcare system, a lot of people have the sense that it kind of covers everything, and therefore paying out of pocket for a cancer treatment or a cancer test or anything like that somehow like they shouldn't have to. It's just not the way it should be. And while I am in full support of everybody having free access to the very best that medical science can offer, and that's what we're working to create here, in the meantime, the reality of the Canadian public healthcare system is actually 1/3 of every dollar spent on healthcare is spent by you out of your pocket privately. So essentially, we already do have a two-tier system in Canada. In the United States, as you're well aware, if you live there, you pay insurance, or if you're lucky enough to have the money to do so, which can be many hundreds of dollars and even thousands of dollars, depending on the coverage that you want and the size of your family each month. But that allows you access to some of these innovations that aren't available in Canada as kind of frontline or starting. So the reality is in Canada, think of pharmaceuticals, think of massage therapy and dentistry and those kinds of things. Those are things you're already paying out of pocket for. So if there's a part of you thinking, gosh, why do I have to pay to get these tests so that I can get the proper treatment through my public health care oncologist? Well, it's the same thing as why do I have to pay for dentistry, or why do I have to pay out of my pocket for the drugs that I need, whether it's insulin or whatever it happens to be, to keep you alive. So it's not ideal. We don't like it. We're working to change it, but that's the reality. There's a lot more that you can do to help yourself to have a better outcome for your cancer treatment, but you have to go looking for it or find someone like Alex and his team who are able to find it for you. Mm-hmm.
Thank you for watching CTOM TV. Subscribe below and stay informed.